to our Glomcom seminar series. Today's speaker is Dr. Samih Nasr.
Thank you. Okay, so this talk will be in monoclonal gammopathy associated renal diseases in renal pathology. So as you know, kidney lesions associated with monoclonal gammopathy can be divided into those associated with high tumor burden, and here we're talking about light chain cast nephropathy and intracapillary monoclonal IgM glomerulopathy, and those associated with low tumor burden, and here we're talking about MGRS lesions, which will be the subject of this talk. I wouldn't really have enough time to discuss light chain cast nephropathy. So as you know, MGRS is defined by the IKMG as a plasma cell and B cell clonal proliferative disorders that produce nephrotoxic monoclonal immunoglobulin and do not meet hematologic criteria for specific therapy. So if you have one of these lesions, magos, smoldering myeloma, smoldering waldenström, low-grade CLL, low-grade lymphoma, plus a kidney lesion due to monoclonal gammopathy, this is now MGRS. So kidney lesions associated with MGRS are driven by the physicochemical characteristics and molecular structure of the monoclonal protein rather than by the characteristics of the clones that produce them. And the monoclonal protein in these lesions can cause kidney damage by multiple mechanisms, most commonly by deposition in the kidney parenchyma, sometimes by crystallization in the kidney, either intracellularly or extracellularly, and rarely by other mechanisms, such as activation of the alternative pathway of complement, autoantibody activity, or cytokine activity. Let me see if I can move this here. Okay, that's better here. For example, in light chain deposition disease, the plasma cells secrete monoclonal immunoglobulin light chain that have peculiar characteristics of their variable domain, including hydrophobic residues, abnormal glycosylation, and positive charge. These characteristics promote their aggregation and deposition in the mesangium and along negatively charged glomerular and tubular basal membranes. In light chain proximal tubulopathy, the secreted monoclonal immunoglobulin light chain bear mutations in the variable domain that render them resistant to degradation by the lysosomal system in the proximal tubules, so they accumulate as crystals or inclusions that disrupt lysosomal function and cause cell injury. In the case of glomerulonephritis, the monoclonal immunoglobulin, which is usually an intact immunoglobulin with both heavy and light chain, can cause glomerulonephritis in two mechanisms. A direct mechanism due to its size and physicochemical characteristics. It gets entrapped in the glomeruli and activates the classical and possibly the lectin pathway. And this activates, the complement activation causes influx of inflammatory cells, glomerular hypercellularity, damaged GBM, and ultimately glomerulonephritis. And this is likely the case in PGNMID, immunotactoid GN, and cryo-GN. Or it can cause glomerulonephritis in an indirect mechanism in the case of C3 glomerulopathy associated with monoclonal gammopathy by intervening with the regulation of the alternative pathway of complement. And here you get glomerular deposition of components of the alternative and terminal pathway of complement without the monoclonal protein, causing similar downstream inflammatory effects leading to glomerulonephritis. Another distinct mechanism is crystallization of the monoclonal protein in the renal vasculature in the setting of crystalglobulin-induced nephropathy. And this crystallization is caused by FC-FC interactions of the monoclonal protein or interactions with albumin. This may lead to endothelial cell injury and activation of the coagulation cascade, predisposing to thrombosis, occlusive changes, and ischemic injury to the kidney and other organs. So these MGRS lesions can involve one or more of kidney compartments. Lesions that involve glomeruli only are PGNMID, C3GN, and immunotactoid glomerulopathy. Light chain proximal tubulopathy mainly involves proximal tubules. Cryo-GN and crystalglobulin-induced nephropathy involve glomeruli and vessels. On the other hand, immunoglobulin-related amyloidosis and MIDD tend to involve all kidney compartments involving glomeruli, vessels, and tubular interstitium. So clinically, these MGRS lesions have or share 4 characteristics. They have a progressive course if not treated. They usually don't respond to immunosuppressive regimens used for polyclonal nephropathies. They have a high risk of progression to their corresponding hematologic malignancy, with few exceptions like PGNMID, and they have high rate of recurrence after kidney transplant if the monoclonal protein was not eliminated prior or immediately after transplant. With regards to renal presentations of these lesions, vary from nephrotic syndrome with or without decreased GFR to nephritic syndrome with decreased GFR to subnephrotic proteinuria with decreased GFR, and only rarely present with acute kidney injury, and that's in the case of Crystalglobulin-induced nephropathy. Workup for suspected MGRS usually starts with kidney biopsy, and if the kidney biopsy showed a monoclonal lesion, then the next step is detection of monoclonal protein in the serum and urine, if these were not done prior to kidney biopsy. This is followed by clonal identification and the search for extrarenal manifestations. I will briefly address these 3 steps, but I will focus on kidney biopsy. So this is an old epidemiologic Mayo Clinic study done on a population of Olmsted County that found the incidence of maggots in individuals above the age of 50 to be about 3%, which jumps to about 8% in men older the age of 80. This is another study on a same population that found the incidence of non-diabetic glomerular disease to be a 9 per 100,000 per year. So these 2 conditions can coexist coincidentally in the same patient, and not every patient with monoclonal gammopathy and kidney disease has MGRS. This is a